Well, hey, it's Matt Roush.
And Mike Brennan.
And you're watching the M-Squared TechCast at MITechNews.TV right here at Podcast Detroit, home of fine podcasts, as well as ours. So, but right now we've got with us our very own expert epidemiologist and infectious disease expert, Fred Brown. He of many vaccines and much experience with infectious diseases. And he's going to tell us the latest about what's up with these vaccines, right, Fred?
Well, if you want to go into that, we sure can. Yes, big news. Of course, AstraZeneca was taken off the South African market this morning because they weren't effective in the B1.351 variant. So that was big news. They decided to take it off rather than to risk the fact of getting 1 million people vaccinated and making them think they were protected, and then finding out they weren't. So that's the risk of that.
But Johnson & Johnson, I think they've got their emergency approval now, haven't they?
They've submitted, and we're waiting for the summation deck coming up from the FDA, and then the review by the FDA EUA committee. That's on the vaccine side of things, and that will probably be by middle of next week, I'd imagine.
Okay.
It takes about 10 days.
How many people do you think in Tampa, Florida, and the area are going to experience a dry cough in about a week and be in some trouble?
Yeah, that may have been a super spreader event. I didn't like a lot of the video I saw of all the guys in the bars without any masks on, and all the collectiveness. They worked pretty hard on trying to keep everyone pretty separated, and having 25,000 fans in a 65,000 stadium, and 7,500 of them were healthcare workers who had been vaccinated. But I looked at the stands and I couldn't tell what their separation policy was when I looked in. They were a lot of people who were really tightly bundled together, which worried me.
Well, it supposedly looked more full than it did, because a lot of what I thought was people in the stands was actually cardboard cutouts.
Yeah, exactly. It was only.
I mean, it looked. As far as I know, they can't get infected, but who knows?
Oh, well, how's everything been going to you guys? You are looking very formal today. I'm very impressed.
Well, I had to go into the office to finish up a report today. It's easier for me to do that in the office, so that's why I'm here.
Well, hey, I put together some stuff that might answer some of the questions, but if there are more, then let's go into them.
Go ahead, run with the ball there.
Let's go do that, and here we go.
Screen here so I can see.
So last time we left off, we kind of talked about the fact that they were, well, let me show you what Michigan looks like, I guess, first of all.
Yeah.
And let's go to slideshow here, and here we are. So the 8th, you can see what's happened is we've gone through a big, massive peak that was that basically was, this is the new cases, right? So about 4 days after you get exposed, it's about between 2 days and 14 days, but usually about 4 to 5 days after you'll start to get that dry cough. And sure enough, you can see what happened, toward the end of right around Thanksgiving, right here, right? A couple days later, boom, we had a big spike, and we were hitting over 10,000 cases a day on several days in the Thanksgiving time period. And then, of course, we ramped back down again, and then had another, we started ramping back up right around January 1st after the big holiday season, and travel around was done. Kind of January 3rd, 4th, I think was the weekend. And sure enough, 3 or 4 days later, we have a big little spike. And now we're continuing down. And that's really a cause to celebrate. But you can see that despite us going down, we were so high that, you remember that big peak and scare we had? We were one of the worst states in the country in April back here, where we were, because we're the auto industry and we had a lot of travel going back and forth to Asia, where we had the viral outbreaks. Detroit was literally one of the top 3 or 4 cities in the country on a per capita basis in terms of outbreak issues, after New York, and I think California also was in that boat initially. But we were really scared right in here, and we were only at around 1,500, 1,700 cases a day. We are over that right now. So just imagine, here we were kind of panicked in April, and now we're just saying, well, that's sort of standard. It's sort of standard for us now. We're anticipating this level of issue. And the problem is, these new viral variants are coming through, and there are a couple of things that were concerning about the viral variants. We went through some of them the other day, but the first big thing that was reported last night from the London School of Tropical Medicine was not only are they've kind of 70% more transmissive between 30 and 70%. Well, we think around 56% overall transmissive increases were anticipated in the R values, and about 70% overall more infectivity. But here, with this, the London Tropical School said they were also 30 to 40% more deadly. And so that means that, in the past, when we had 1,000 people, if you had 100,000 people getting sick, 1,000 of them would die. Now, it'll probably be 1,300 of them will die. And unfortunately, more of them will get sick because of this high transmit. 70% more will get transmitted because of the infectivity rate. I'll show you what happens when that occurs in a second. So here's what Michigan looks like overall. And you can see that this is on a per capita basis. And so some of these areas up here with very small populations in the UP, a couple of new illnesses really cause you to spike. But the point still is that since we're a peninsula, we're sort of sheltered. And that's sort of nice. But where we have the borders, again, I went too fast. Wisconsin border, we're just on fire. Illinois, Indiana, on fire. And Ohio on fire. And that's because those states actually have a higher risk level than we do. And so those counties on the border, which have the traffic back and forth, are more at risk still. And we showed that in the past, and it's still the case. Safest place to be is sort of the center of the state on a per capita basis, interestingly enough. So I wanted to go back when we talked last time about one of the areas you guys know so much about, and that is social media and technology being a factor in acceptance and the resistance we're having. And interestingly, we started doing some research. There are about 276 anti-vax sites in the United States right now, and they have about 56 million followers. So if these followers are negative about taking a vaccine, and we need to have over 280,000 people vaccinate, and you throw in children and they may also be impacted because a lot of these people who are following the vax also have children. They want to make sure their children are safe. The anti-vax sites, that would indicate that we would be under the level that we need to get to be herd immune, which means that we'll all have to continue to wear masks because we don't have enough people to protect who are vaccinated to protect those who are not. And that's a real shame because that really affects, the way we live our lives and who we see and how much we are, how mobile we are. But if that anti-vax trend continues, and as I said, I think they're advantaged in that media because of the algorithms. The algorithms point people toward very inflammatory and sites. So if you kind of do a search for children's baby food, you're going to be steered and offered this opportunity to look at an anti-vax site. If you go onto Facebook, if you go onto YouTube and so on, they'll put up those sites as something that they know attaches people, attracts them in and keeps them on their sites longer so they can sell more ad revenue. That's just a shame. And I think we're going to lose that fight on the scientific side. And here's what things look like overall. What's interesting, this is what the acceptance rates are around the world. And you can see that the acceptance rates of a vaccine in China are very high, Brazil very high. That's because Brazil has a terrible problem right now, and China, of course, they're at a point where just a little bit of vaccination will cause them to go over into the herd immunity spot, right? They're already at only 4 out of 1,000 people getting killed from this vaccine. We're at about 4 in 100,000. We're at about 700 in 100,000 getting killed by the vaccine. So China doesn't have very far to go before, with just a couple of vaccinations, they'll be they'll be close to herd immunity. So they know that. UK is under fire, so they want a vaccine. Mexico also, but you can see the United States are sort of in the middle. We're sort of 50-50 about it. What's interesting is we are an outlier on this chart. Do you guys see why? We're the only country to get more positive about a vaccine.
Oh, yeah. Okay. Yeah, the red dot's farther to the right than the blue dot.
Yeah, that's just it. So actually, we're on not a bad track. If hopefully we can get more and more of that same trend going, that would be great. And this is October to December, and so hopefully, hopefully we've gone a little bit further now in January, and we're getting more and more people interested in the vaccine, seeing that now more people get vaccinated, there are really no serious adverse events to worry about for the average person, and no deaths except one that we're studying by someone who injected themselves, who was a medical worker who was contraindicated for the vaccine.
Well, what in the heck is wrong with the French? Of course, they all smoke anyway. But still, I don't know.
The French are really negative, and you'd think, the country of Pasteur, for goodness sake, right? They'd be all for it. Right. But for somehow they're off on the wrong track. And I'm actually working with Institut Pasteur to help the French get, kind of a better sense of the fact that this is less bad than they think. Part of it is that they had vaccinations. They kind of pushed vaccinations to the public health system. People are unhappy about being pushed so hard, especially. I'll have to look more to starting to work with them, but they're worried about it because obviously you only get 40% of people, injected, and boy, you got no herd immunity at all in that where we have an R value that's so high for this virus. So just wanted to show you how we sort of are in the middle of the road. So this isn't. And I can't tell you how much trouble I had in Africa with the village elders and the medicine men and so on, but we're sort of, and so in almost every society you see this, kind of, I'm not sure if I want to take the vaccine or not. Hopefully, as people get more informed, they will want to take it because it is just, from a risk-benefit standpoint, hugely beneficial. And it's going to be increasingly beneficial as we move forward, even with these variants. And the reason for that is these variants, even though it looks like the vaccines are not as protective with the vaccine as with the original wild type Wuhan vaccine, you can see that this is sort of the results that we have right now. And AstraZeneca finally did separate out. Remember, we showed you the slide a couple of weeks ago, I think, when we got this data originally. I said AstraZeneca has to separate out the South African variant numbers. And the other thing they have to do is they have to look to see who has already been infected. It turned out that 30% of the people who were in the trial in South Africa had already been infected, and that was actually an exclusion criteria. So they went through the entire dosing with an infected person. What that means is if you're infected and survived, you already have really high antibody levels, right? You already have antibodies against the disease. So all of a sudden, if you're 30% of that, 30% of the population you vaccinated, they didn't get 2 doses, they got 3 doses. And the first dose was much more protective than we would have anticipated because they already had sort of the equivalent of an initial shot, right? So they took all that data out and they realized, we don't got nothing. We're not seeing much of it. We have to develop another vaccine. And so that was very disturbing because obviously we are using, as we pointed out last time, we are using the same antigen for AstraZeneca with a couple of minor modifications as we are for every other vaccine that we've developed. Every one of them is using basically either what they call a PS2 or the original full spike protein of the Wuhan virus to cause the immunogenic effect of the vaccine. So we're talking about an antigen that doesn't look like it's going to be working against the new variants. And that's a big problem. Despite that, though, we are going to be impacted by the B1.17 virus, and the 1.17 virus is much more infective. So what happens is there are 2 things that cause infection. The first thing that causes infection is how much inoculum you're spreading, right? If it causes a lot of shedding, a lot of viral shedding, and you cough, and you'll shed a lot more of those particles that come out and infect you. That's the first part. That's stage 1. Stage 2 is how much more infective are each particle. And it turns out that the 1.1.7 virus spews out. If you catch it, you spew out a lot more inoculum, and that inoculum is much more infective. So it's 85% higher binding coefficients and 56% more extra spewing out when you cough or breathe. And when you combine those things, the whole thing is significantly more infective than what we're used to protecting ourselves against. And that's why I was saying we have to double up on our masks. So we have to be more distant to people even than we were before, because by February, late February, we think this is going to be the dominant strain of virus in many states. What happens is this virus doubles in its spread every 10 days. So right now in Florida, it is 7%. So if it doubles, you go 14, 28, 40, 56, and then you're already in 3 weeks. It's going to be probably well over 90% of the total virus that we're fighting in this case. In California, we're starting off at 5%. So it's 5, 10, 20, 40, 60. And so you got about 5 weeks away from that. In most of the United States, we're probably about 1 to 2%. So we've got a little bit of time, but in our major cities, if we keep traveling around and keep not being unprotective, it's going to spread really quickly. So that's what we're worried about, the B117 virus. The South African variant is here in much lower levels. The Brazilian variant also is here much lower levels, and those are much more dangerous even than the UK variant, because they actually escape our vaccines. The B117 virus does not escape our vaccines. If you get vaccinated, you will kill it, which is why you want to get vaccinated as soon as you can, because you want to not have a lot of vaccine around, where when the new variants come in, they can mutate with it, reproduce with it, mutate with it, and cause a superbug to occur. So the faster we can get the vaccines out right now, will be the less we're going to have to fight them at the end of March, where we think we're going to have a big scare because of the B117 virus as it becomes very prevalent. So you can see here are all the results, and you can see that basically J&J, what you really want to look at if you're looking at this, now remember J&J is only a one-shot vaccine, and so it doesn't look quite as effective. If they're doing studies on a two-shot vaccine, which will be hopefully read out, sadly not till late December. I think the government's going to push them to go faster than that. So we'll see whether 2 shots actually this is just the primer and the booster. In this case, J&J is only the primer, and you can see that what's interesting about this is that it does prevent severe COVID by 85%, and that's really what we want. We want to have something that if you get the sniffles, you're not going to be so worried about it, but if you get down with something that's severe, it'll kill you. The issue with COVID, though, is that it has so many long haul effects, and we'll talk about that in a second. It's not just you got a little pneumonia and you cut and then you're done after you've resolved the initial COVID disease. The issue is that it causes so much damage. It's actually a microvascular disease more than it is a respiratory disease, and that causes permanent damage to a lot of different organ systems, and we'll take a look at that in a second. So does this?
All right, Jeff, with that, I have to back out. I have to head to another meeting, but Fred, we'll talk to you next week.
That's all right. I'll still stay with you, Fred.
How much time do we have still?
Oh, you got lots of time. Matt has to leave.
Matt, it's good to see you. We'll talk next week. I'll catch you up with everything. Don't worry.
All right.
And
take care.
So does this answer the basic questions about what's working, what isn't working? So
yes, very much so. So thank you for that, and I'll talk to you guys next week.
Okay, sounds like a plan. Thanks, Matt. So basically, Pfizer and Moderna, you're protected with the British virus. You probably are not protected against the South African or the Brazilian virus. They haven't published their results, but they're all developing new vaccines. And when a commercial person, when a business does that, and they have a patent with the original ones, they've got lots of investment in the original ones, and they're already making new vaccines, you can bet they've gotten some bad results. I don't want to speak too much out of turn, because I do know some of this data, and my guess is that they don't protect very effectively. And you can see the big one was Novavax, where they actually reported South Africa results. Overall, 89% effective. Overall in South Africa, 49% effective. We have what we call a cushion, which means that you've got some flexibility in how much room you have, and whether you want to build out a new vaccine. When you drop from 90% to 50%, you've escaped the cushion. There's too much of the virus out there that's going to get you to call it protective anymore. And that was a big piece. Interestingly, J&J didn't go down quite as far, but they still haven't released their full data sets, and the way they released them so far, I want to see those, and that's going to go out to the FDA, as I said, early next week, I believe, as a full data set. We'll see that, and then we'll be able to talk about it in much more detail next week, if that's all right.
Yeah, sure.
That's where we are right now. And here's why the variants are so worrisome, right? We talked about the fact that the B117 virus is about up to 70% more transmissible, and has about a 30 to 40% higher fatality rate. So here's the difference. If you've got a high transmissibility piece without a significant, so suppose you have 50% higher transmission, right? Versus 50% higher fatality. Which one is worse? And the answer you can see here is that it's much worse to have a very, very transmissible virus. It's much more deadly ultimately than having a high fatality virus, all else being equal. So if you have a choice between a mutation, you probably want to take the more deadly one, not the more transmissible.
Oh, okay. Good to know. Yes.
And the reason is you can see that if you have a highly 50% more transmissible, you're going to get about 1,000 extra deaths. Whereas if you have just something that kills you twice as much, you only have about 100 extra deaths in the baseline start of 100, right? 2 times more for 50% more. And anyway, that's the way the math works out. And so so the idea here is you want to work really fast. If you've got a chance right now to kill off the virus way down at time, this is a 1 month timeline of what the COVID does. So if you have a chance to kill off the B1 virus way back on the left-hand side of the matrix, you're that much further ahead. If you're having to wait, to get the vaccine, get injected, and so on, get a lot of population, and you wait that month, you've got that much more disease to kind of try to control, that much more people in the hospital, that many more people dying. So that's why we're focused so hard on trying to get even though it's not as effective against the later variants, we want to get as much injection done as possible. So that's sort of a sense how that looks for a 10,000 infection scenario. What are the 2 options for COVID?
Well, which brings us back to most people want to get a vaccine. Most people can't get a vaccine because of supplies issues. I'm in favor of the Michigan National Guard marching on the Pfizer facility in Kalamazoo and seizing all those so that we can have them here in Michigan. You think that's too radical, Fred? Or
I think Michigan has a right to some of those. I think it may be slightly radical. Pfizer may have something to say about as well as the rest of the country, but of course, we maybe will seek some out. I'm joking. We don't do that. Don't do that. Yeah. Because ultimately, the way that we're going to get this best is if everybody in the country gets vaccinated, if everybody in the world gets vaccinated, because you keep having these pockets of guys who aren't vaccinated, and they create new variants that then turns out your vaccine didn't work against, and then there you are back where you started from. And that's the problem we're having.
It seems like the developed world is kind of getting this under control, but what I worry about is the undeveloped world is so many more people and they have such poor healthcare, parts of Africa, South America, Central America. How do we deal with that?
So we've done the numbers. We think that we will have about 80% of the developed world inoculated. That means OEDC countries inoculated by the end of this year. Other people who want to take the vaccine. There may be a group that don't want to take the vaccine, as we just saw. But if you want to take the vaccine and they're all available, we'll have 80% inoculated by the end of the year. Guess how many of the poor countries? That means the kind of 94 countries that are considered, poor, and guess what percent of the population will be vaccinated there?
Hard to say.
Less than 20%.
That's what I was worried about. Then what? And then the cycle just keeps continuing, right?
That's the problem. It becomes endemic. You have enough virus already in the environment, the prevalence is so high, you just can't get rid of it. And we're there already. We're not going to get rid of this virus in our lifetimes. Unfortunately, we're still fighting against polio, even though we've got a vaccine. We'll be fighting against this. Your grandchildren will be fighting against this.
So it's sort of like you're going to have to get your COVID shot every year, like you get your flu shot every year, and things like that, right?
That would be a bad scenario if the vaccines are that ineffective. But so I was part of the Academy of Science discussion last week, and was nice to be invited to some of it. And they are going to recommend WHO and the CDC that we prepare for that scenario, which means that what we do with the flu is we actually have monitoring sites all over the world. and we look and see what flu variant is prevalent, and then we predict which ones we want to actually get vaccinated against, because the flu starts in birds and moves over to people. If you can tell what's going on with the birds, and then say, okay, here's what we're going to do with people. Here's what the variants are that we have to vaccinate against. And then 6 months ahead of schedule, we then create all these vaccines that we hope are going to be the ones that are going to be protective against what we think will be, the flu variants we have to fight. And so that happens every year, and we go through the cycle. And so right now we're thinking about which ones are going to be the most prevalent ones. We're all over the world, especially in China and other places. We're trying to figure that out. We're recommending that we actually do that with COVID as well, that we try to predict what variants we're going to have to fight each year. We try to create a universal coronavirus vaccine, but in the interim, and then boost that every time against the variants that we think are going to be most prevalent to fight. That's the worst possible scenario, but it's better to prepare that now, and invest in that now than it would be to wait and then find out that we need it and not have anything available for against the new variants that we could have predicted now in the fall and next winter when we have another surge coming. So that's what we've recommended, and it's expensive to do that, but we think it's worth it to just in case. Better to be safe than sorry. So we're trying to get in front of it, over-responding, as we always try to do in the epidemic because of the exponential growth, and we always work linearly. So that's a little bit about why we're so worried about these variants that cause so much more transmission and are so much more infective than the original one.
Now, have you had a chance to talk to your friends at the WHO who went to China to investigate? I know we talked about this last week.
They're still there. They're still there. There are 10 of them out there, the scientists. They would, so in order for us to really positively finally determine that, they'd have to understand the source, the source variants that China was experimenting on. And it's unlikely that China will give us that. So I think that's going to be kind of a mystery for a while. My feeling, if you can get a sense of this, is that this is, coronaviruses are really getting more powerful over time with the change of the environment that we've got. We've got more people crowding into smaller spaces, and we got closer and closer relations with animals in the wild. That we're going to see a lot more of this. And my sense is that my opinion is this is truly a natural event that we have to get ready for. And we'll see what they find. I'm still waiting to hear back. They're still doing the. Last week they actually got into the big test facility at the invitation of China, but that doesn't tell you quite enough. Yeah. You actually need to understand what they're experimenting with, what the source of those vectors are, and so on, in order to really understand whether that could have possibly occurred through an escape. So we'll see. If they give us that data, then we'll know for sure. But if they don't, which is likely, they for defense reasons, they don't want to tell people what they're experimenting on, what they are susceptible to. That's sort of a natural. We probably do the same thing if they asked us. So that's sort of where we are. What's interesting about this is that even if our vaccines do reduce our symptoms, it turns out that long haul effects, it doesn't matter if your symptoms are very strong. What matters is what part of your body was infected, and whether or not those parts of the bodies are permanently damaged. And what we're starting to find is that probably we think that it's probably more than 20% and less than 30% of people have long haul effects. And you can see these long haul effects take 7 weeks. Well, in this case, you can see it's almost 25 weeks, and there's still people have them. And they occur in about 3 cycles. So if you're out there and you've had an asymptomatic, or you thought you had COVID, weren't sure, and are feeling a little bit bad for a while, you can see these clusters that are occurring in your body. And basically, the first part of the clusters occur in the gastrointestines. You're going to have loss of appetite, vomiting, diarrhea, and you'll have the dry cough and rattling breath and so on. But the gastrointestinal effect is something we don't really talk about. And those effects you can see, start very high, and then they start tapering down a little bit. So over the course of time. Cluster 2 are something that pretty much stays even all the way across your infectivity rate. And it starts right up front, burning toes, tachycardia, cardiovascular system is a little bit unhappy. And it usually takes a little bit more time to than the first couple of days and the first onset of symptoms to feel this. It'll take a little bit. It'll take several weeks into a month or so before you really start feeling the bone aches, tightness of chest, the breathing difficulty caused by scarring, the chills, and fatigue. The fatigue is almost always there. So that occurs all the way through. And then finally, at stage 3, you've got a lot of those factors. Plus, you have an elevation of the cardiovascular problems, the dermatologic problems, the hearing loss, tinnitus issues, if you've got those, the joint pain. And so you've got to be watching for these symptoms. And if you have them, even if you don't think you've ever had COVID, go and get it checked out. If you have had COVID and you feel any of these things, go and talk to your physician about these long-term effects. This was the largest study we've done on this so far. It's what's called a meta-analysis. We've combined 14 different countries and the results. So this is happening all over the world. Don't feel like you're out there being an outlier or complaining. It is a real problem for about 20% to 30% of all patients who have this, and go see your doctor about it. Hopefully they can at least start to get you on a course of action that'll help reduce the symptoms. This did not look at some of it looked at the cognitive areas. It did not look at the psychological areas, which are different. But there are an awful lot of people who have an increased amount of depression because they're not able to talk to everyone and be as social as they used to. A lot more anxiety by being cooped up and not knowing what's going on. And sadly, a lot more drug and alcohol abuse. So those are some of the long haul effects. It's not just something, this COVID is something you want to avoid. The vaccine may not protect you from a lot of these other issues. We have a lot of studies to watch. So be sure not to get COVID if you can avoid it at all costs. So how are we doing for time? We're doing good?
Still got about 5 more minutes or so.
Yeah. So one of the things that's happening with these long haul effects, and you'll see out there, is that there's a lot more healthcare that's happening through telehealth. And you can see the increase in telehealth overall. I don't know, Mike, if you participated in telehealth or not. Have you tried it out?
No, I haven't tried it out yet.
Yeah, well, especially around April, people were afraid to go see the doctors. And we were at that point, we were all broadcasting, for goodness sake, be careful if you go see a doctor. And Matt was talking about trying to see his doctor time because he was worried about his knee and all the protective, the correct protective measures that his doctor had put up so that he wasn't feeling comfortable to visit. But a lot of doctors, people were still scared. Didn't have quite so much knee pain, maybe. So they went and they said, no, you've got to help me out. Let's do this on the phone. And what's interesting is that went up 6,000%. So that's 60 times. Today, about 60% of all healthcare providers offer some form of telemedicine, and 30% of patients actually use them as their preferred interaction with doctors today. So it's and that's moved from almost not, those numbers are almost 0 and 0, before COVID. So it's a huge change. We think that probably about 30% of all, about a 30-fold increase overall, is going to be what's going to happen as a result of COVID. And especially these long haul effects where have multiple experts have to get together and talk about what's wrong, try to see if you can if they can help you. And so we think that this is going to be a permanent change in the healthcare delivery system. The other big change in the healthcare delivery system is the Internet of Medical Things, the IOMT. And you can see here that there are all sorts of smart textiles that can measure your skin temperature, measure what you've eaten, what you're sweating. There's a lot of smart patches that goes everything from electrocardiograms to diabetic patches to microneedle patches that they're putting in right now, so that you don't have to stick your finger all the time. You can simply read on your cell phone what your reading is, or via a detector what your reading is. I don't know if you've seen the rings that tell whether you've got blood pressure problems or not. Those are coming out. The wristbands that look at electrolytes, metabolites, all the apps that are available now on the Apple smartwatches.
On the Android too. I have an Android phone, and I was looking. Now those smartwatches, they're kind of on the expensive side, but
God, yeah,
they're like $300, So, but I mean, they test everything. So I'm toying with the idea of getting one, because you can get one now that'll relay the information to your doctor's office.
Right. And so you get that exactly right. So you started to get to a point where it's having impact on your medical, on the medicine that you're going to have, and it gives you a longer term view of, and quite a bit more precise view of exactly what's going on with your body over time. And that can help there's, with medicines, it can help with interventions and so on. One of the things I noticed is that, I'm jumping through. One of the things you'll notice, though, is that I'll have to show it to you tomorrow. But basically, when you look at all the different companies that are out there, I've got a nice diagram. We'll go into it tomorrow. All the different companies and all the different ways they're trying to interact with patients. Everything flows through one of four companies: Apple, Google, Facebook. So the FANG companies are doing extremely well. And the risk is, of course, that they're going to have so much information about us, even on a de-identified basis, that it's going to be difficult for the normal everyday person or everyday competitor to compete with those guys, because they'll have so much more information about your insurance, about this, about that, about you, that it's going to be challenging. But here are some of the things that I have talked with a number of employers, and they want to get more involved in vaccine. And here is sort of a chart that indicates what you can do if you want to start getting more involved. If you're an employer, there are a couple of things you can do. First thing is you have to want to understand how much intervention do they want to get involved with, and that really is determined by what your risk level of your employees are, right? So if you've got a whole bunch of very elderly employees that are high at risk with multiple comorbidities, you probably want to get more involved than if you've got a lot of younger employees that are healthy and don't have any underlying conditions that would put them at risk. And you might want to kind of split off the employees to say you're more at risk. We want to help you more. You're less at risk, so maybe you don't be quite so pushy. You can see that it moves from passive to active. Passive, you really are sharing information, right? So if you're trying to share information, you're going to require, and I've switched the two top ones. Apologies, I'll get the right one to you. You want to require a proof of vaccination, right? But at the very low level, you at least want to inform people, hey, here are the vaccines that are available. They seem to be safe. Here's your recommendation to get vaccinated. Here are some phone numbers you can call, the 211 numbers, for example. And then finally, you might actually say, I'm sorry, but in order to work here or to work, to attend this special football event, I want to see a proof of vaccination, right? That's informational. Then you've got actually ways of incenting people. And here you see you can offer a stipend to get a vaccination. So if you got a student or if you got an employee, you say, hey, here's some money, go get yourself vaccinated. Don't worry about it. Or you might want to give them a PTO to vaccination. You might want to give them tickets to an event. You say, hey, great. Why don't you go to football? If you want to go to the University of Michigan football games, get vaccinated, and we can give you tickets to the event. Or you can actually start gamifying and start making it competitive of different groups in your community, how much you're vaccinated and so on. That sort of incentivized intervention. And then finally, active means you want to actually get involved with the distribution of vaccines directly. You can say, you go to University of Michigan on this day, and you've got a special time to do that. We'll create on-site vaccination clinics, or you can even start to try to procure your own vaccines. Some companies are big enough, some universities are large enough. Working with a couple right now who actually want to go ahead and talk to J&J about buying their own vaccine, for example, and pushing it through their hospital for their students, for their faculty. That's some of the things you can do at a different levels, depending if you're an employer and you want to get more and more or less involved.
Traditional four-year students love Lawrence Technological University's thriving campus life, but LTU has always met non-traditional students' needs too. Lawrence Tech offers over 100 degree and certificate programs that can get adult students started or back on track. And most of our classes are conveniently offered evenings at our beautiful Southfield campus or online, so you can balance your social, family, and work life even while you power up your career. Lawrence Tech, where Blue Devils dare.